Looks like we've got about 15 people right now. So let's go ahead and get started. So for those of you just joining, we have Dr. Jared Cook, who's one of our nephrology attendings, who's with us today and has agreed to participate in the educational efforts of our service. And he and I started residency at the same time, or maybe a year apart, but we graduated in 2017. And he's been with us ever since. And so we're glad to have you today. And our topic is going to be acute kidney injury. So I'll let you get started.
Thank you so much, Ashley. And thank you guys for inviting me. Can you guys see my screen?
Yeah.
Awesome. All right. Just a little note, I did steal some of these slides from Rashida Tolwani, very graciously loaned them to me. I don't have any disclosures. So I know you guys have other business to get to today, so I'll try to briefly touch on all these things, but I mainly want to focus on how do we define acute kidney injury, the diagnosis and evaluation, treatment, and a little bit about prevention. So AKI has a huge impact on our health system, affecting 21% of all hospital admissions and over 50% of ICU patients. It's a major risk factor for developing CKD and end-stage renal disease, and is an independent risk factor for mortality. Dialysis requiring patients in the ICU have the worst outcomes, and over 2 million people this year will die with an AKI. So you guys can pipe up an answer or put it in the comments. Any guesses what the mortality of ICU patients who require dialysis is?
B.
What was that again?
I said B as in boy.
B as in boy. Other thoughts? It's actually over 40%. Patients requiring dialysis for AKI, especially in the ICU, have a very high mortality. So let's move on to definitions. So these are the KDIGO definitions that help to sort of standardize our criteria for AKI. And probably the one that we are most familiar with is an increase in serum creatinine by 0.3 within the last 48 hours. Other criteria will be 1.5 times the baseline creatinine that's occurred within the last 7 days. And there's also a urine volume criteria there, less than 0.5 mils per kg per hour, which is a little bit harder, I think, to quantify, especially on the floor where we get, you know, as you've experienced, strict ins and outs are kind of a myth. Probably the creatinine increase by 0.3 will be the one that we use for the definition most often. And you may have heard of staging of AKI. I think it is not as clinically important for you to do this, even for nephrologists. I think we use this more for research purposes, but it's pretty self-explanatory. The worse the elevation in creatinine and the smaller the urine output, the worse the AKI. But like I said, I don't think it's really clinically that meaningful. Just a couple words about, you know, why creatinine may not always be the most reliable marker for kidney injury. It's influenced a lot by age, muscle mass, other factors. It doesn't reflect structural injury. It's a delayed marker, so it often does not elevate for 2 to 3 days after the injury. Giving fluids may dilute the creatinine and falsely decrease it, delaying diagnosis. And, you know, between hospital labs, there's a little bit of variation. And in this kind of conceptual model for AKI, creatinine is actually a pretty late player. So the damage has already occurred, the GFR has already gone down, and that's when creatinine is elevated. And at this point, there's not a lot that you can do to try to reverse things. So an ideal biomarker for acute kidney injury would occur closer to the time of damage. And you may have heard of some of these biomarkers for early detection of acute kidney injury. So this dotted line here is the serum creatinine. So notice that if time 0 is the time for kidney injury, creatinine is a pretty late peaking marker, whereas you have these other things like NGAL or Chem1 that peak earlier after the damage and may be better biomarkers for early tubular damage. So we do have a commercially available test now for these biomarkers that includes both NGAL and Chem1, and it's called NephroCheck. Most hospital laboratories don't have this. UAB does not have this. And it's not a perfect system, but it is out there. So really, when somebody has an elevated creatinine, I think the onus is on us to try to figure out what caused it, and that really informs what treatment that we can give the patient. So as you all probably remember from your training, there are 3 main buckets for causes of acute kidney injury: pre-renal, intrinsic, and post-renal. Intrinsic AKI is usually, these are the most puzzling causes because the differential is much broader. And we're going to talk about each of these causes of intrinsic AKI in turn. I won't spend a whole lot of time on post-renal AKI because I think that we do a really good job checking for it at UAB and managing it. So really anybody with an acute kidney injury, especially if you feel like pre-renal causes are not to play, then everyone needs a renal ultrasound, or at the very least, a post-void residual bladder scan. And if they have hydronephrosis, place a Foley. If something's weird, like there's a big stone in the ureter, or you placed a Foley and the creatinine doesn't get better, or the hydronephrosis doesn't go away, then maybe call urology. But those post-renal, usually easy to detect and pretty easy to treat. So that's all we'll say about post-renal or obstructive AKI. I show these charts just to kind of give you a little flavor for the causes for AKI in the non-ICU and ICU population. So notice that ATN, even in the non-ICU population, still takes up a pretty big piece of the pie here. But if you put pre-renal, which is this slice right here, and obstructive, that still accounts for most of your causes in the non-ICU setting. Whereas in the ICU setting, it's overwhelmingly ATN. And this is a busy slide, but I just put this here to represent that usually it's not just one cause. Often AKIs are multifactorial, and there's a lot of different things coming together in a perfect storm to cause an AKI. So a little bit about pre-renal AKIs. So these are the most common cause in the non-ICU and community settings. And essentially, they all cause decreased renal blood flow in some way. So either they're truly volume depleted, have a decreased effective arterial circulation, or are on some medications that may impair renal blood flow. And prolonged pre-renal state may lead to ATN. So volume depletion, I think this is probably one of the most common causes that you guys will see and that you are very good at fixing, usually without getting our attention. So GI fluid losses from diarrhea, vomiting, hemorrhages, burns, things like that. These can be corrected really quickly with appropriate volume resuscitation. And appropriate volume resuscitation for most patients is isotonic fluids. So either LR or normal saline, either one works. Some other causes of pre-renal AKI that you may not think of as pre-renal. So things that cause decreased effective arterial circulation like heart failure or cirrhosis, those are technically pre-renal causes of AKI that you wouldn't want to treat with IV fluids. I'm not going to belabor those things here because usually if those things are at play, nephrology, cardiology, hepatology are all on board giving advice. Sepsis in the beginning causes a pre-renal injury. Certain drugs, calcineurin inhibitors in patients who are on immunosuppression for transplants or things like that. ACEs and ARBs. So they don't, ACEs and ARBs, importantly, don't cause acute kidney injury, but if they're sort of a pre-renal, say they're volume depleted and they're on an ACE and ARB, because of the way they affect renal blood flow hemodynamics, those patients are going to be more likely to have an AKI. And if you examine the urine microscopy of someone with a pre-renal AKI, you'll often see these sort of ghostly looking casts. These are hyaline casts, basically just formed by the TAM horsefall proteins that are secreted by the renal tubules. So on to the intrinsic causes of AKI, of which ATN is the overwhelming majority. It's generally reversible, but not always. Risk factors include older age, diabetes, decreased effective arterial circulation, and chronic kidney disease. Ischemic, so that's that prolonged pre-renal state causing decreased renal blood flow. That can cause ischemic ATN. I think we're familiar with a lot of drug-induced ATN, so common things that we use in the hospital: vancomycin, aminoglycosides, NSAIDs, contrast. So that would be iodinated CT contrast. Pigment nephropathy, so rhabdomyolysis, hemolysis, and sepsis, also very common cause of ATN. And if you look at the urine microscopy, you will commonly see renal tubular epithelial cells. These sort of kind of look like fried egg appearance, and granular casts. And if they are kind of have this dark pigment to them, we classically call them muddy brown casts. Abdominal compartment syndrome usually starts out as a pre-renal injury, but often progresses to ATN. So I did want to say just a little bit about it. So it occurs because of increased abdominal, intra-abdominal pressures. And intra-abdominal pressure greater than 20 millimeters of mercury, and any sort of organ failure, it qualifies for the diagnosis of abdominal compartment syndrome. And so you have to measure their bladder pressure in order to diagnose that. Now, the classic studies where we did that were in intubated patients who were paralyzed. And so that's typically not the case on patients who are on the floor. But if you have a strong clinical suspicion for somebody that may have abdominal compartment syndrome and they have a bladder, Foley, then you can always measure a bladder pressure. So these are the people that you should think about that in. So trauma patients that have had a lot of resuscitation, patients with massive ascites, recent surgery with a tight surgical closure, burn injuries, bowel obstruction, pancreatitis. Those are people that you might think about abdominal compartment syndrome in. AIN, acute interstitial nephritis, is caused by lymphocytic infiltration of the interstitium. So the classic triad of fever, rash, and eosinophilia, you very rarely will see all three of those in a patient. And really it's more of a clinical diagnosis, based on the timing of their kidney injury and other factors. So drug-induced is by far the most common cause of AIN in the United States. So you're probably most familiar with AIN from beta-lactams, but can be caused by a host of different drugs, including fluoroquinolones, PPIs, which are very commonly used now, as you know, NSAIDs, even Lasix. There are infectious causes of AIN, autoimmune, malignancy, but most commonly we're thinking drug-induced. So what you may see on the urine here is they will have some proteinuria, some hematuria and pyuria, and importantly, white blood cell casts, and their urine cultures are negative. So your differential for culture negative pyuria, so white blood cells in the urine and a negative urine culture, is pretty small. And AIN is definitely way up there on your differential for culture negative pyuria. Importantly, the urine eosinophil test, the Wright or Hansel stain, is not very sensitive or specific for AIN. So please, no more urine eos. Okay, we really should take it off of the lab orders. And here's a nice white blood cell cast. Anybody know what other clinical problem you can see white blood cell casts in besides AIN? Yeah, I think Kendall was mouthing pyelo. Yes, pyelonephritis. So that should be, they should have a positive urine culture, have, CVA tenderness, imaging findings, things like that, that are going to point you more towards pyelo than AIN. So like I said, most likely from a drug. So try to figure out what the offending drug is, which is not always easy, and discontinue it. If it's infectious, treat the underlying infection or the systemic illness. Glucocorticoids may be helpful if you start them early in the course of AIN. And typically, we don't consider treating patients with steroids unless we have a biopsy-proven AIN. So at this point, definitely a nephrologist is involved in the care. Acute glomerulonephritis, I'm not going to belabor this because, again, if you suspect this, a nephrologist is probably going to be driving the care here. But think about this in somebody who has kind of a nephritic presentation. So they have non-nephrotic or nephrotic range proteinuria, hematuria with dysmorphic red blood cells in the urine, and maybe RBC casts. So urine microscopy, very important in the diagnosis of these patients, but usually will require a renal biopsy for definitive diagnosis. So if you're ever thinking that somebody may have acute glomerulonephritis, please don't hesitate to just consult nephrology. We do typically send a lot of the serologic studies, but I see commonly there will just kind of be a shotgun of all of these rheumatology labs, which is a little bit overkill sometimes. So we would love to help you with that. Here are some pretty pictures of dysmorphic red blood cells. And so you may have classically heard them described as Mickey Mouse looking cells. So they have these little odd looking blebs coming off of them. And the reason why the cells look like this is because they're being forced through an altered glomerular basement membrane in the glomerulus. So being squeezed through that weird filtration barrier is causing their shape to change. And here's some red blood cell casts. So you can clearly see inside the cast, there's these cellular elements that have that biconcave shape of a red blood cell. Acute vascular syndromes, these are things that I think a lot of times are not on the differential, but in certain situations we should think about them, including atherombolic disease, thrombotic microangiopathies like TTP, HUS. HELP is also kind of on that spectrum. And then there's macrovascular diseases like renal artery occlusion, severe abdominal aortic disease. You may think about these in somebody who has severe hypertension. You may want to get a renal ultrasound with Dopplers to look for renal artery occlusion. But again, that's a pretty uncommon acute presentation. So a few words about atherombolic disease. These are patients who have usually atherosclerosis, and it's usually after a precipitating event like a left heart cath. So sort of catheterization, arteriography, something like that. And classically, they will have some skin findings. You may see this on a board question when you recertify livedo reticularis and digital ischemia. We'll look at some pictures of that. They may have other embolic phenomena like TIAs or strokes, spinal cord infarcts. They can have GI bleeding from bowel infarcts and things like that. And here are the characteristic skin findings. So this sort of reticular, lacy looking rash, that's livedo reticularis, and then these embolic looking skin findings on the feet. So if you ever see that after, say, a heart catheterization with an AKI, think atherombolic disease. Here's a nice picture of a renal biopsy. Just to orient you, this is a glomerulus. These are some unhappy looking renal tubules in here. And this is a medium or large artery that has a big cholesterol plaque in the middle of it. So no bueno. Another kind of ding-ding thing that you might see on tests with atherombolic disease is eosinophilia or eosinophils in the urine. Atherombolic disease can be another cause of eosinophils. I've never seen this entity in practice. Talking to some of the other attendings, you know, maybe it's like a once or twice in your career sort of thing. So this doesn't occur very often, or at least we're not catching it. So in these patients, you shouldn't anticoagulate them. They should be on sort of, you know, general goal-directed medical therapy for coronary disease and things like that. They may need dialysis. They frequently need dialysis, and steroids are controversial. Intra-tubular obstructions, these are like crystal diseases or myeloma cast nephropathy. Again, usually at this point, a nephrologist is going to be involved in the care. Common crystal induced diseases, tumor lysis syndrome from uric acid crystals, acyclovir, sulfa, methotrexate, ethylene glycol in patients where you suspect an ingestion. multiple myeloma, again, causing myeloma cast nephropathy. These things cause intratubular obstruction and intrinsic kidney injury. So here are some pretty uric acid crystals, hexagonal crystals, in tumor lysis syndrome. So this part is kind of the meat of what I wanted to talk to you about. Key steps for evaluating and diagnosing an AKI and trying to figure out how it happened, because I think this is where we can usually be of some help with thinking about therapy. So as always, obtain a thorough history and physical, and review the chart in detail. Try to assess their volume status. That's very important because often the only therapies that we can offer are giving fluid, taking away fluid in the appropriate settings. Order a renal ultrasound or a post-fluid residual bladder scan, like we said, to evaluate for obstruction. Examine the urine microscopy. If you guys ever need help with that, whoever is on the nephrology consult service, we would be glad to help you, and review some urinary indices. We'll talk about that a little bit later. So what kinds of things do you look for in the chart or the history to try to identify the insult? You're looking for volume depletion. Do they have an episode of hypotension? Do they have cirrhosis or congestive heart failure? You're looking for drug exposures, contrast exposures, infections, toxins, myoglobin, CK elevation, uric acid, and these are sort of the things that I look at every time I'm consulted about an AKI in impact. So I usually go to if the AKI happened in the hospital, I will go to the day that the creatinine was first elevated, and then I will start looking a few days before that. I will go back and look at their vital signs. And often you can see an episode of prolonged hypotension maybe 1, 2, 3 days before the creatinine starts to go up. So that's pretty indicative of either a pre-renal or ATN type AKI. Something kind of sneaky that you may have to hunt for: if a patient gets admitted to your service after an operation, which I think is, that's a very common scenario for hospitalists who are co-managing these patients. They may look fine once they get to the floor and you have no idea why they have an AKI. But if you go back and look at the anesthesia records, maybe they had some prolonged intraoperative hypotension requiring pressors, or maybe they lost a liter of blood and required several blood products in the OR. So that's an important place to look in somebody who's just had an operation. And if you don't know where to find that, if you pull up reports and documents, I think maybe 1 or 2 from the top is anesthesia records. So that's a really good place to look. Look in the MAR for medicines that the patient has gotten in the last few days for potential nephrotoxins. And this nephrology flow sheet is a really valuable tool to look for potential nephrotoxins. So if you go to the results tab and change, there's a drop-down box that says lab or whatever you're looking at. If you just scroll down through that drop-down box and select nephrology flow sheet, it will show you any nephrotoxins that have been given in a certain time period. You can, like anything in impact, you can back it up as far as you want to and look for potential nephrotoxins. So it's pretty inclusive. Dr. Tolwani worked with with Cerner to make this application. The only thing that doesn't show up there are contrasted studies. So I put that down here. Look at your radiology imaging studies and see if they've had a contrast study in the last 48 to 72 hours. Vanc troughs, if the patient is on vanc, are important to monitor. And of course, go to iView and look at the patient's urine output over the past few days. But if I want you to take one thing away from this slide, it's probably looking at that nephrology flow sheet. I think that can really be helpful sometimes. This a very busy slide, but a few things that I wanted to point out about some clues that we can glean from the urine. So in pre-renal AKI, the kidneys are still working, okay? The tubules are still doing their job. And so when the kidneys sense a decreased blood flow, either true decreased blood flow or decreased effective arterial circulation, the tubules are going to kick in and start to reabsorb sodium. And so that's going to cause a low urine sodium. So a low urine sodium, often that's a clue to pre-renal injury. And they'll often have a high specific gravity, again, because the urine's being concentrated as the kidneys reabsorb sodium and water. And they may have normal urine microscopy or hyaline casts. In contrast, ATN, the tubules are no longer doing their job, okay? They can't fine-tune the filtrate anymore, so they're not reabsorbing sodium, okay? So usually the urine sodium is high. They will have a specific gravity of around 1.01, and that has a fancy name called Isostanuria. Basically, it just means that the concentration of your urine, it's the same concentration as your plasma, okay? And you may find those muddy brown casts or tubular epithelial cells in your urine microscopy. And again, with AIN, the big clue here is pyuria or white blood cells in the urine with a negative urine culture. So always think about AIN if you have white blood cells with a negative urine culture. So FENA, a few words about FENA. You guys love to order it. Everybody loves to order it. I don't think it's particularly clinically useful in most situations. So I think the biggest thing to remember is it's really only reliable in the setting of oliguria. If your patient is making plenty of urine, then FENA is not very reliable. If the patient has pre-existing CKD, they may have an increased FENA because of their decreased creatinine clearance. If they're on diuretics within the last day or two, then FE urea may be a little bit more reliable. It's also affected by any sodium-containing IV fluid. And it's not very sensitive because there are other causes for a low FENA other than pre-renal AKI, such as hepatorenal syndrome, early contrast nephropathy, rhabdo, sometimes acute glomerulonephritis, early obstructive uropathy. So it's not a very sensitive or specific test. So I think a urine sodium by itself is often pretty helpful. And we really don't, in most situations, need that FENA in order to make diagnostic and clinical decisions. So a lot of drugs have been investigated for treating AKIs, and unfortunately, there really has not been a lot of favorable data. And the only FDA-approved treatment for AKI is dialysis. So really the focus of treatment is optimizing their volume status, removing offending agents, and prevention is key. So how do we prevent AKIs? So we want to find those patients at highest risk. So patients who have underlying chronic kidney disease, diabetes, who are elderly, who have cardiac and liver dysfunction. These are our highest risk patients, and we want to try to prevent ATN in those people. Remember that changes in the creatinine are often late manifestations of renal injury. And I think this is key. Just because the lab is not red doesn't mean that it's not abnormal. So be thinking critically, especially about little old women, with poor muscle mass, who have a quote unquote normal creatinine, because a creatinine of 1 in them may be abnormal. So in these people, you want to take great pains to maintain normal renal perfusion. So try to avoid hypotension in these patients, avoid nephrotoxins as much as possible in patients who are at the highest risk. So this is just another way to think about that. So in these high-risk individuals, you want to discontinue all nephrotoxic agents when possible. So I see this a lot in our post-op patients that we're co-managing with ortho. So maybe they have CKD, or maybe they have some hypotension during the OR. And then per protocol, what do all of these patients get ordered after their hip replacement? NSAIDs, okay? So that's another place where we can be of some help, in these high-risk patients. Maybe make sure they don't get any NSAIDs after their orthopedic surgery. Again, ensure that their volume status and perfusion is optimal. Monitor urine output and creatinine in these high-risk individuals. Avoid fluctuations in their glucose. And importantly, consider alternatives to contrasted imaging. So think about when you're ordering CTs, do they really need the contrast? What are you looking for in these patients? So sort of to sum it all up, I wanted to go through this case together. This is kind of a made-up patient that has a lot of potential causes for AKI, and I wanted to just sort of think through it with you, sort of summing up all that we talked about. So you got a 65-year-old guy. He's admitted for a lower extremity ulcer with biopsy-proven osteomyelitis. So this is your bread and butter. You guys say this every day. So he gets started on some antibiotics, some cefazolin. He undergoes angiography and stenting of the iliac artery using low osmolar contrast on day 1. Day 2, he becomes febrile, and you switch his antibiotics to Vanc and Gent based on culture sensitivity data. Day 3, his fever's better, his creatinine is at baseline. So it looks like you're doing a good job treating his osteomyelitis and sepsis. And then on day 10, his creatinine is increased to 3, and his urine output is decreased. He's got diabetes, hypertension, high cholesterol, coronary disease, a little bit of baseline CKD. He's on a statin, some blood pressure medicines, and of course the Vanc and Gent in the hospital. He's a little bit hypertensive, pulse is fine, no rash. He's got some decreased peripheral pulses. He has that ulcer on the tip of his second toe. His renal ultrasound is normal. And these are his labs on that day. So mild anemia, no leukocytosis, normal eosinophil percentage. His creatinine is 3 from a baseline of 1.5. And his urine specific gravity, you see there, he's got trace blood, trace protein. And this is his urine microscopy. So what do you guys see? Anybody can speak up.
Muddy brown cast.
Yeah. So it may be kind of small on your screens, but within these casts, there's not any really cellular material. It's just sort of kind of amorphous debris, really small, and they're kind of, kind of mucky brown appearing. So yeah, these are muddy brown casts. So the patient has ATN, but we need to figure out what's the cause. So which of the following is the most likely cause of the patient's acute kidney injury? Cefazolin, cholesterol emboli, contrast, or gentamicin? So before we answer, I want to go back to the excellent day-by-day history. So if we're thinking that it could be cefazolin, well, he got that on day 1, and really only got 1 day worth of cefazolin. His creatinine remained at baseline, and then suddenly, acutely on day 10, his creatinine increased. So that's not looking like a very likely culprit to me. He did undergo angiography with stenting on day 1, and then became febrile. So maybe atherombolic disease is a possibility. So let's keep that one on our differential for now. And then what were the other choices? Contrast or gentamicin? So he got a contrasted study on day 1 with his angiography. What do you guys know about the timing of contrast-induced nephropathy? It's usually within 24 to 48 hours. So usually it's pretty close to the timing of the contrast exposure. So anything beyond 48 hours, pretty unlikely to be contrast. And then the last one, the last option was gentamicin. So gentamicin was started on day 2. He's continually getting it while in the hospital, and then acutely on day 10 is when the creatinine goes up. So we've knocked out cefazolin in contrast. We've still got cholesterol emboli and gentamicin on our differential. Cholesterol emboli, I think, less likely. We don't get any, there's no mention of embolic phenomena, none of those sort of, juicy ding-ding test words like livedo reticularis, no pictures of that, or a stroke or anything to lead us to believe that he's had other embolic disease. His eosinophil on his leukocyte differential is pretty normal. So I think that's pointing us less towards cholesterol emboli. So I think sort of by the process of elimination, I would pick gentamicin. I think we've all heard a lot about aminoglycoside induced nephrotoxicity. It's something that we get taught about in training, but in practicality, I think we don't know as much about it as we could. So usually it occurs 7 to 10 days after drug initiation. That's the key, is the timing aspect. So the timing fits here. They're usually non-oliguric. They have an ATN type picture with granular casts, and the treatment is supportive. They usually recover if you remove the offending agent. So in summary, AKI is bad. It's an independent risk factor for mortality and for progression to CKD and ESRD. We've standardized the definitions, so we're catching more AKI, treating it better. It's not a disease. It's a syndrome that usually has multiple multifactorial causes. And so we have to identify patients who are at risk. We talked about those biomarkers again. They're not widely clinically available or in use right now, but something to look forward to in the future that may help our timely diagnosis and treatment of AKI. There's no real treatment for ATN. It's just supportive care. So prevention is of paramount importance. So risk identification, recognition, diagnosis, working up the cause, and follow-up are important in managing these patients. So wow, yeah, like I finished a little bit early. And I would be happy to entertain any questions that you guys have, anything specific or general about AKIs. Any confusion about when to get us involved? Do you guys feel comfortable about when to consult nephrology?
I had a quick question.
Sure.
A lot of times when we get urine studies, maybe it's like a day after admission, so they've gotten 24 hours of fluids. Is that going to adjust our urine sodium too much to interpret it?
Yeah, especially if they have gotten sodium containing fluids, it does affect it some. But I think still the urine sodium in isolation is a good test, but it's not perfect. Yeah, especially when they've already gotten some fluids. Other questions?
How much can we trust the lab's interpretation of the kind of microscopy of the urinalysis?
That's a good question. So I think the microscopy part, a lab technician is actually looking at the urine. So, I think they're only reporting what they're seeing there. However, I would say most of the time when the nephrology team is sitting down and looking at urine microscopy, we have a very systematic approach to it, which may be a little bit different than what the lab technicians use. And we're also looking at it in a clinical context, whereas the lab technician is just looking, at a slide. So I think it's important, especially if you're not sure what the cause is, or if you're suspecting GN, to examine the urine microscopy. And what I was going to say about when to consult us, I mean, honestly, no, there is no right answer, and we're happy to help no matter what the question is. I think times when we definitely want to be involved, I think if the creatinine has gone up for 2 consecutive days and you don't have like a definitive etiology that you feel like you're treating well, we would love to be involved in. If somebody has a normal baseline creatinine and presents with a creatinine 3 or above without like a definite reversible pre-renal or obstructive cause, I think it would be good for us to be involved. Anybody with an active urine sediment, so blood and protein in the urine, I think nephrology needs to be called. Of course, anytime you're thinking about dialysis. But honestly, you know, we're happy to help no matter what the clinical scenario. And if you ever get pushback from a fellow or anybody on the consult team, please feel free to contact either myself or Dr. Tolwani so we can give them some education, because we would love to help you guys.
The outpatient version of the consult, we often get sort of newly diagnosed late stage CKD. Is there a good referral process?
Yes, so it may be easier just to let the consult team know so that we can help you obtain follow-up. But essentially what I usually do is I send an impact message to the nephrology access pool. So if you go to impact messages and then change the person search to a pool and put in nephrology access and say that, you know, like this patient was in the hospital and had an AKI or was diagnosed with CKD, please schedule, you know, with a nephrologist for a new patient visit, and you can specify the time frame. We also have a chronic kidney disease clinic, which is run by nurse practitioners, and they can often see like sort of more urgent post-hospital discharge. So if you need somebody to be seen in 1 to 2 weeks, like for an AKI follow-up, the CKD clinic is often a good venue for that, because they have more flexibility in their schedules than some of the attendings do. But the short answer is, if you ever get, if you forget that or get confused about it, just give one of us a call and we can help arrange follow-up. Other questions?
Jared, well, I think that was a fantastic presentation, a great review of all our basic nephrology principles and when to get you guys involved. So we're so